afternoon and welcome to the Immunodeficiency Foundation's Lunch and Learn series. Today's program will explore APDS with Dr. Elena Hseih of Children's Hospital, Colorado. My name is Emma Mertens and I'm the Program Manager of Community Health at IDF. On behalf of all of us at the Foundation, I'd like to thank you for joining us today for this Lunch and Learn. We are excited to host this webinar for the IDF community. IDF is dedicated to fostering a community empowered by education. We want you to remember that IDF is committed to our community, serving you as a trusted resource through the use of technology and innovation. We are here to give you the tools and information to become empowered and offer you our compassion, understanding, and support to emphasize that you are not alone on your PI journey. Today's Lunch and Learn is part of IDF's regular series of bite-sized programming that will provide diagnosis-specific information and support to our community wherever they may be. Today's Lunch and Learn is made possible by our core services partners. It is due to their partnerships and contributions that we can offer programs such as this to the PI community. Please join me in thanking our 2023 sponsors: CSL Behring, Grifols, Takeda, Horizon Therapeutics, Accredo, Octapharma, Pharming Healthcare, AstraZeneca, Bioproducts Laboratory, Kedrion Biopharma, Enzyvant, X4 Pharmaceuticals, CVS Specialty Pharmacy, and Chiesi Global Rare Diseases. Before we get started, I would like to point out a few housekeeping items to keep in mind for today's webinar. This afternoon, we are using the Zoom webinar feature. Attendees should be able to see the slides and our presenter and be able to hear us both speak. Attendees will not be able to activate their video camera or their microphone. There will be the opportunity for questions after the presentation. You are welcome to submit any questions you have for our presenter as you think of them throughout the session. We kindly ask that questions are relevant to today's Lunch and Learn topic. Please type them only once in the Q&A box in the control panel on your screen. Please do not include any personal health information, as all questions will be anonymous and read aloud. A brief disclaimer: please remember that information presented during this event is not intended to be a substitute for medical advice or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational event. To learn about IDF and explore our resources, please visit our website at www.primaryimmune.org. The website offers a wide variety of both online and printable resources for anyone seeking information or support for PI. We can also help you find an immunologist or a PI specialist in your area with the clinician finder. IDF has a growing library of resources for APDS. On our website, you can find articles highlighting the release of the diagnostic code for this condition last fall, as well as the very recent FDA approval of leniolisib for the treatment of APDS. We also have a video of last year's APDS Lunch and Learn with Dr. Eve Wu if you would like to check that out. IDF also offers monthly programming and events. We host monthly Lunch and Learns and bi-monthly webinars covering various topics facing the PI community. And we also have Get Connected groups, peer support, Ask IDF, and our annual PI conference. Connect with others in the PI community at our 2023 Walk for PI. With events in 8 cities across the US and a virtual coast-to-coast walk, anyone can participate. Did you know that 24 IDF research grants have been funded solely by our Walk for PI? Visit www.walkforpi.org to get in on the fun and help make a difference for our community. And now I am so pleased to introduce our presenter for today. Dr. Elena Hseih is the Assistant Professor of Immunology, Microbiology, and Pediatrics at Children's Hospital, Colorado. Welcome, Dr. Hseih.
Thank you very much for the kind invitation. You can all hear me okay? Okay, great. I'm now going to share the screen and you can see this okay? All right. Okay, great. So I will be talking today about APDS as announced. But I wanted to take a minute to also talk a little bit about CVID because APDS is often, at the very beginning, patients that have APDS do meet criteria for CVID, and that may be sort of the beginning of their journey. So I wanted to take a minute to talk about that. I'll be happy to answer questions at the end. I'm not going to be able to sort of pay attention while I'm talking during the talk. I can't multitask that well. So I will come and look at the Q&A at the end of my talk. All right, so let's get started. So this is kind of the agenda for today. I'm going to talk about the clinical presentation of CVID and the diagnostic criteria, and really what are the immunological abnormalities that I identified and how many of those are essentially part of the immunological abnormalities for APDS. I will go through a case to kind of take us through thinking about APDS diagnosis and treatment. And really, I think for everybody that's on the webinar today, we're all familiar with a very complicated picture of CVID in terms of the clinical presentation, the genetic underlying etiologies, and really the molecular in the context of immune cellular heterogeneity. So I'll talk to you a little bit how we can slowly untangle that, and I'll end with talking about the immunopathogenesis and treatment of APDS. But the thread of APDS will be there throughout the whole presentation. Okay. So let's start with CVID. So just move this out of my view. Great. So it is, as its name defines, common in the context of inborn errors of immunity. It's 1 in 25 to 50,000, but it is very variable. You can present with autoimmune / autoinflammatory complications, which are all listed here. With the major organs involved, we tend to see our lung, the gut, and then cytopenias. And then malignancy is the other compartment that'll become most relevant for APDS. And then, of course, there's the immune deficiency part, primarily with recurrent cytopenic infections, with 75% of patients having pneumonias. So let's talk then about the diagnostic criteria. And I think this is quite important because as a patient, you want to understand whether you truly meet criteria. And then if there are any physicians or health staff on the call, I think this is useful to know that in general, CVID is a very broadly used label, but there are actually pretty stringent criteria that are often overlooked. And what I'm presenting today is the latest consensus from the European Society of Immune Deficiency that had a consensus published in 2014. These are the major criteria, and they actually all must be met. We don't tend to make a diagnosis until you're above the age of 4 years old, and I'll say why in a minute. Then patients need to have a low IgG, so meet hypogammaglobulinemia standards, at least 2 standard deviations below the mean. We must rule out other causes of immune defect, meaning other genetic causes, other causes for, say, severe combined immune deficiency, and also make sure that we're also not dealing with a secondary cause of hypogammaglobulinemia, meaning that maybe someone has kidney problems and you're losing lots of protein, then your antibody levels will be low. That's a secondary problem. Okay, so this is the reason why, as you can see, one of the primary criteria is the level of IgG. So when we examine a patient and when you go see your doctor, this is why we start with checking immunoglobulin profile, where we look at IgM, A, and G. So first, does someone meet all of these 4 criteria? Then the next, we must exclude the secondary causes, as I mentioned. Some of the examples I already said. If you're losing protein, immunoglobulin is just another protein. There are some medications that will lead to secondary hypogammaglobulinemia, and they're listed here, so important to consider. And then also malignancy can lead to secondary hypogammaglobulinemia. So let's make sure we rule that out, that we meet the major criteria. And then if the major criteria are not met, then this falls in the bucket of hypogammaglobulinemia of unknown origin or significance. And then if these are met, then we proceed with further criteria. So is there evidence clinically that the immune system is not working properly? So we must meet 1 or more, and that's increased susceptibility to infection, poor response to antibiotics, having breakthrough infections despite being on prophylactic antibiotics, infections to things that you have been immunized to, if there's chronic sinus disease, and then if there's evidence of inflammatory autoimmune disease. So this is why when we also take a very detailed history when we see our patients, if these criteria are not met, we wouldn't rule it out because the other must be met 4 have been met. So that has been met. Then we moved on here and we say, well, if none of these clinical aspects are present, it's possible, but is unlikely. Now, if one or more are present, then we kind of move on to the next tier to think about this. Is there supporting laboratory data to say that, okay, clinically, there seems to be a problem with the immune system, as in it's not working enough, if there's laboratory evidence to say that. And then here we have different items of laboratory assessments, and 3 or more must be met in this level. So that's if there's reduction of another different type of immunoglobulin, so not the G, right? So we already established the G is low. Now the question is the A or M also low? The other part is that the B cells are the cells of your immune system that make antibodies, particularly the memory B cells that have this marker CD27. Thankfully, nature was kind to us. So all the cells in the immune system, they have labels, they have proteins on the surface that then if they express that protein, then they can tell us that they're this type of cells. So B cells, for example, express CD19 and 20. That's sort of for general B cell. Then specifically, if they express CD27 in large amounts or high, then that's considered a memory B cell. And then memory B cells are the ones that tend to then make antibodies. So if you don't make enough antibody, then you should show evidence that there's a reduced amount of those B cells that make the antibody. Also having increased level of CD21 low B cells. These are the B cells that are generally called innate or exhausted, meaning like B cells that have been working and been activating for a long time. We tend to see an excess of them in CVID. And these are assays that we do at the clinical level, and they are flow cytometry assays, meaning that we do look at things at the single cell level. Then we also check vaccine responses, and if they're impaired, that's concerning. In younger children who maybe haven't been vaccinated yet, or if we have some older children who also haven't been vaccinated, we can check isohemagglutinin. That's just it's a type of antibody that you make that if you are not AB, but if you're A positive or B positive, the minute that you're essentially ingesting foods, you will make an antibody against the other type that you're not the blood type for. So we can check for that. Is there any evidence of autoimmunity? For example, if you have anemia and then are you Coombs positive, which would indicate that the anemia is due to an autoimmune issue. And then is there some, are there some genetic variants that would predispose to CVID? I would say this is a little bit of a softer call. Just as we learn more about the literature, these variants have, they technically have a modifying effect, but I think it's very variable depending on the person. So you must meet 3 or more. So then if we evaluate a patient, okay, so you met the 4, there's clinical evidence that there's immune deficiency. Is there laboratory evidence that there's immune deficiency? And this is why we check the vaccine titers and also by flow the B cell phenotype here to be able to assess this item. And if the answer is no, we're still sort of dealing with, well, it's possible, it's unlikely, but it's possible, right? Nothing is most things are not impossible in medicine. And then if the answer is yes, you do meet this level of criteria, then we say, okay, at this time, once you have met that you must have hypogammaglobulinemia, you do show clinical evidence that there's immune deficiency, and then you do show laboratory evidence that there is foundation for that immune deficiency, then we say you probably have CVID. The things that we must rule out, I say we have to rule out that there's a secondary reason. So, maybe your medications that make the IgG level low, maybe there's malignancy in question, protein loss, etc. You also must make sure that we're not dealing with a profound T cell defect that can also have B cell defects, right? CVID, we tend to think you don't make antibodies, so then it's a B cell problem. But you can also have a T cell problem because T cells help the B cells. But if it's a profound T cell defect, then we're kind of out of the realm of CVID. So we have to make sure that there's no evidence of profound T cell deficiency. And then there's some numbers and thresholds that we measure. And this is why also, in addition to evaluating the B cell phenotype by flow cytometry, we'll also look at T cells, B cells, and NK cells. And we also check the breakdown of the T cells in the naive versus memory. Now, when we look at vaccine responses, you might be wondering, why do we check response to multiple vaccines? Why not just do one? And that's because we're assessing different ways in which the B cells respond. So the B cells, in order to make antibody, they need most of the B cell responses need T cell help. That's called a T-dependent B cell response. However, there are some B cell responses that are T cell independent, so they can do it without the help of T cells. And that's in the context of polysaccharides. So if you have basically a bacteria or you received a vaccine that's mostly composed of sugars, the T cells do not see sugars, so they cannot help the B cells. So that's a T cell independent response. This is a reason why we asked for vaccine responses to Pneumovax. This vaccine is composed mostly of polysaccharide or sugars, and it elicits a T cell independent B cell response. So I'm assessing this arm of the immune system. There's also a T cell dependent B cell response that is the most common one, and the one that we think is most durable. And in that context, you need T cells to help. And that is why we check response to tetanus. That's a vaccine that's mostly protein. And then HIV and diphtheria, it's a vaccine that has sugar and proteins. So it's a little bit composing the entire spectrum, right? The vaccine that is only protein, the vaccine that is sugars and protein, and then the vaccine that is sugars only. And this will we assess different aspects of a B cell response. So in the B cell phenotype, I mentioned that we look for those cells that are memory, that are the ones that are in charge of making antibodies, and we ask, are those reduced? And this is really pictures of B cells. And like I said, thankfully we have these proteins on the surface that will help us immunologists to decide what type of B cell you are. And this is what we call a class switch memory B cell. So they have CD27 that makes them memory. They express CD19. All B cells do that, express CD19. And then they have class switch, meaning they have moved on to become IgG positive, which it's not pictured here, but you can imagine it. And because then they're IgM and IgD negative. So they have lost this. So you go from looking like this as a baby naive B cell, then you lose the D, and then you lose the M. And then when you lose D and M, you would express G, or it's also possible to express A. And then we call that a class switch memory B cell. These are the ones that make antibodies. The other cells that make a lot of antibodies are called plasmablast, and they express a lot of CD38, and we look for those also in the assay, the flow cytometry assay that I mentioned. And then the transitional B cells, these tend to be increased in the patients with CVID because the idea is that there's a little bit of a problem for rest in maturation. So you don't fully mature to these, but you have, and so then you're stuck somewhere in the middle, and that will be the transitional. Also the CD21 low B cells right here. So you could be stuck here, and then it will be increase of these cells and increase of these cells as well. Okay, so we're now sort of to the next level criteria, which it's often not pursued. And I would think as we learn more about CVID and we learn more about the genetic etiologies that are under CVID, is actually quite important to look at the tissue where the symptoms are present. So for example, if there are lung symptomatology, and then we're looking for evidence of pneumonitis and looking for lymphocytes in the lung, you really can't see that unless you have a biopsy. If we're dealing with GILD, which is also, it's granulomas in the lung, you also have to see that on biopsy. If we're dealing with liver issues, the nodular hyperplasia, meaning basically lots of cells are not supposed to be there. Also, you can't really see that unless there's a biopsy. Also, we have lots of patients who have a kind of IBD-like type of picture, but not quite. There's a very peculiar look to it where there's no plasma cells in the gut. Typically, we do see them in the normal scenario. And there's also lymphoid hyperplasia, meaning lymphocytes. So you can see that the theme here is that you have lymphocytes. These are the T, B, and NK cells that are in the tissues when normally they shouldn't be there. They should just be circulating in blood. And really, it's very hard to arrive to that specific item unless you do a biopsy. So I'm not saying, I'm not advocating here that every patient should have a biopsy. I'm saying that if we have a patient that has a particular clinical presentation involving a specific organ, and we're really having trouble coming up with a treatment that's effective, it might be time to do a biopsy to really look at what immune cells are there. And it is important for diagnosis, and it is also important for thinking about treatment and therapy. So if there's no histological evidence that it looks like CVID, we're still in the realm of possible. However, if there is evidence, then this is definitely probable CVID. Okay, so if you fall in the category of probable CVID, then you probably have a clinical and a laboratory picture that looks like this. with recurrent pulmonary infections, and then either plus minus evidence of autoimmunity or autoinflammation, definitely the hypogammaglobulinemia, poor response to vaccines, a B cell picture that suggests that there's an arresting maturation that you can't get from the naive to the very mature B cell. And really you have eliminated the possibility that you have a profound T cell problem and you're older than 4. And the reason to be older than 4 is because when I show you that picture of the T cell dependent and the T cell independent B cell response, you really don't develop that T cell independent B cell response until you're over 3 or 4 years old. Well, therefore, if we check that and that's decreased and shows an arrest and maturation or an immature arm of the B cell response, then that could be part of normal physiology. And it would be unfair to call someone CVID because actually they are expressing a part of normal immune maturation. And then along to support that clinical picture, these are the laboratory studies that we would do. We do a CVC with the differential to see if the lymphocytes are low, make sure you're not losing protein in your kidneys, look at the immunoglobulin profile, vaccine responses, B cell phenotype, lymphocyte subsets, and then look at the T cell breakdown. Okay, so that's the end sort of the diagnostic criteria. So now that you're all experienced CVID diagnosticians, the question is, okay, so CVID, as you can see, the criteria is many levels, but you can meet CVID in many ways, and everybody with CVID looks very different. Now more and more we're learning that with the ability to do genetics faster, quicker, and cheaper, we have been able to discover more and more genetic disorders. In fact, 10 to 20 are discovered every year. So when you look at patients that have CVID, and there's been many studies where the genetics have been done, there's a certain percentage of the patients that will have a very specific monogenic disorder, meaning a defect in one single gene that can explain their picture. It is still a pretty small slice of the pie, right, of everybody that has CVID. However, if you take the small slice and you say, well, what are the genetic disorders that are the most common that underlie this picture of CVID, you can see that the 3 most common ones, largest sections of this small pie, is PI3 kinase gain of function, or APDS. This is the gene name, right? So everything in immunology has multiple names. So the gene is called one name, one acronym. Then the protein actually, it has a different one that's similar but different. And then, of course, we have the sort of clinical name of the disease. So the immunology has 3 names. And we have CTLA-4 haploinsufficiency, and then we have LRB deficiency. So for the talk of today, we're going to focus on here. APDS, what's not reflected here is APDS2, and I'll show you kind of what the difference is there as to how one is different than 2. And it really boils down to the genetics, but really not very much the presentation. So let me take you through a case on a patient that I took care of back in 2015. This is a patient that I saw, right? And, now that you're all familiar with the diagnostic criteria, we're going to go and think about, okay, with this clinical picture and laboratory testing that I'm going to show you, that's the patient meet criteria for CVID. So this is a 5-year-old girl that I saw, and then she came to me already with this label. And I think I trust physicians that are outside of my own institution, but I like to say that I always trust and verify. So I like to comb the sort of all records and look at the whole picture, and the patient comes new to me, so I want to make sure I have a good understanding of their clinical picture and whether I can improve the treatment, right? They may come to me with a label diagnosis and a treatment regimen, and I think for me, as now being their new provider, I need to make sure that I can optimize the treatment best possible, which I can only do if I fully understand the disease picture. So came to me with a diagnosis of CVID. And then 3 to 4 months prior to coming to see me, she had a very large lymph nodes. So it's lymphadenopathy in the cervical area and the neck and the inguinal, large enough that basically if I walk into the room, I could see it without even palpating it. And then she really also had a very big spleen that essentially she's 5 years old and her belly was rather large, not because she was fat, but because she had a big spleen. And then she also had a history of bloody stools and having sort of diarrhea on and off with fevers on and off. She had a history of recurrent pulmonary infections and pneumonias, low IgG, and actually came to me already on IVIG. She had some mild T cell low counts, so not severe, but somewhat low. The mother also said that she, when she sleeps, she snores a lot. She has trouble breathing sometimes. She gets lots of infections. And she had a pretty high EBV and CMV PCR in the blood. Because she had really big lymph nodes before, she had lymph node biopsies that were done, and they really mainly look for malignancy because that's really the main concerning thing when you see big lymph nodes on a young child. And it was negative for malignancy. So going through now a summary of what we know. So she has a history of recurrent cytopenia infections. Hypogammaglobulinemia already comes from IVIG. I look back, she did have evidence for decreased response to tetanus and diphtheria, has mild T cell lymphopenia. You look at her B cell phenotype and there's decreased memory B cells. The T cells, they are low and they don't proliferate well, but they do proliferate some, meaning that they can work to make copies of themselves. And that's good, right? So you're not dealing with a severe T cell problem. And then the naive versus memory breakdown seems normal. This question of bloody stools, diarrhea, are we dealing with GI disease? Maybe. And she comes on IVIG. So does she fit the diagnostic criteria? She does, right? If we go back to kind of what I just discussed, she totally fits. Now, are there some things here that don't quite fit CVID or the classic picture CVID? One is like, well, I am wondering about this lymphadenopathy, right? They're rather large lymph nodes to just sort of be strictly, quote, run-of-the-mill CVID. And then I'm very sort of trying to understand, what does this GI disease mean? So she has bloody stools, diarrhea. What is the scope? Here is what I'm thinking we really need to do a biopsy. And that's because sometimes the issue is in the tissue. The biopsy can be quite enlightening. Again, as a pediatrician, I try to minimize procedures as much as possible, but sometimes you really have to look there to confidently arrive at a diagnosis. So when we looked in her GI tract, she had something that's called lymphoid hyperplasia. What does that mean? Basically means like if you imagine you have lymph nodes in the gut, that's not normal. And that means there's a lot of lymphocytes, so lots of T, B, and K, right? Those are your lymphocytes in the gut. And then there's a picture here of the respiratory tract. She had a bronchoscopy as well because there's this question that she can't breathe well. She snores a lot. She's had lots of recurrent cytopenia infections. She's already going under for a endoscopy. We might as well also do a bronchoscopy. And clinically, the histological examination you would do in GI tissue is that you will look for, what types of cells are there? And that only gets to a certain level as in like general cell types. So you look for, are there plasma cells there? Are there monocytes, there macrophages, are there lymphocytes? But you probably don't get into the weeds of the types of lymphocytes, right? We typically clinically do not look at, are these T cells, B cells, or NK cells? Within the T cells, I'm an immunologist, so we look at the subset of the subset of the subset, what type of T cell is there. But I am lucky to work at Children's. I work with pathologists, and really here, as I started to put the picture together, and very interestingly, this is where I think as an immunology community, we learn together. I was really thinking about this patient and thinking there is something unusual in the picture here that is not classic CVID. I went to CIS, Clinical Immunology Society. That's our scientific meeting every year. And this is where the paper for PI3 kinase gain of function was published in 2014. And Carrie Lucas kind of gave this talk. Gubu Utso also gave a talk on it. And I'm sitting there in the auditorium just thinking about this and thinking like, my patient really looked like this description. So I walked to pathology, and what has been described as disorder, that there is a predominance of a very particular type of T cells that are called the follicular helper cells. They're called helper because they help the B cells, and they're called follicular because they tend to be in the follicles, which is a very specific part of the lymph node. And recall that I say for this patient, there are these abnormal lymph node structures in the gut. So I went to pathology and I said, well, can we stain for these markers? Recall that I said in immunology, the cells have proteins on the surface that tells us what types of cells they are. The TFH, or the T follicular helper cells, they express ICOS and PD-1, two proteins, and then also BCL6. But I really just asked for the combination of these two. And I said, can we look for these cells? And they say, well, Elena, we can, but typically, right, we don't have reference ranges. Like we haven't done this on thousands of biopsies and we don't know what the normal amount is. And I said, I understand, but I think that if this is the diagnosis I'm thinking about, it wouldn't be a question. It wouldn't be a guess, because it wouldn't be a little increase. There would be lots of them. So then we did the stains, and lo and behold, there were lots of them in the gut. So, right around this time, like I said, this is when this paper was published, and the first description in 2014, well, whole exome sequencing was done on three families that had a history of pulmonary infections, big lymph nodes, nodular hyperplasia, right? So these lymph nodes in tissues where they're not supposed to be. They have a high copies of EBV and CMV in the blood, like my patient. They don't have a lot of naive T cells. That was not the case of my patient yet, but she's young, right? And then when you looked at the T cells of these patients, they had increase of phosphorylation of kinase AKT and hyperactivation of mTOR. What does that mean? That means that the T cells, they have a machinery inside that will tell them to make copies of themselves. And that machinery is dictated in large part by PI3 kinase. That's PI3 kinase job. And when that's turned on all the time, then the proliferation, so the making copies of your cells, happens all the time. So you get lots and lots of T cells, and instead of hanging in the circulation, they just go into the tissues, which is what we saw for my patient. So then, we fought pretty hard to get whole exome sequencing. Back in 2015 was not as easy to do from an insurance standpoint as it is now, and sort of clinical ways. But lo and behold, she had a new mutation in PI3 kinase P110 delta, and she had sort of the phenotype with a lot of TFH. So I was very excited to be able to give our patient a diagnosis, which then the question is, well, did that lead to a targeted treatment? So let me talk a little bit about what targeted treatment looks like in PI3 kinase gain of function. But for me to discuss that, I'm going to take you through what is the immunological pathway that's involved in PI3 kinase, so you can understand what a targeted therapy means. I'll take you also, by now, you have gathered that thinking about the patient and thinking about the publication of that paper, there were a lot of similarities. So I'm kind of going to bring you the clinical picture into what APDS looks like, and explain to you why it looks like that based on the immunological pathway and defect that is involved. And then we'll talk about treatment. So these patients have, a large array of clinical manifestations, the same way CVID does. These are some of them. So developmental delay, failure to thrive. I always ask this as a pediatrician whenever I see patients. Growth is a big parameter that we assess in pediatrics. If you have good growth, my suspicion for immune deficiency tends to be lower. Growth is a very important part. I tend to think about it like you're fighting. If your body's working so hard to fight infections, you probably don't have a lot of energy to grow. Recurrent sinopulmonary infections. We've seen this trend repeatedly, right, with sinopulmonary infections, pneumonias, which then, if you've had them long enough, then you have bronchiectasis, which is just another word for some tissue lung damage. And then we talked about lymph nodes. So we talked about big lymph nodes, chronic lymphadenopathy, nodular lymphoid hyperplasia. That just means lymph nodes in places where there shouldn't be in tissue, right? Your lymph nodes are normally under your mandible, in the neck, in the back of your head. You've all felt them when you've gotten sick, in the inguinal area, axillary, but lymph nodes that are large in your lung, in your gut, in your kidneys, those are abnormal. Lymphoma. So if these lymph nodes continue to grow, they can become malignant. And then you saw that our patient had a high CVV and EMV PCR copy number. And we see that also it's very costly for APDS, and I'll explain why. And then picture of autoimmunity, right? And that could be the gut, like our patient, for example, autoimmune cytopenia. So having anemias, thrombocytopenias, having a big spleen, a big liver, that also is a picture of autoimmunity or autoinflammation. So what are the laboratory findings that we see, right? Going back with the same sequence that we did with CVID, what does the clinical picture look like? Does it look like evidence that the immune system is not working properly? What do the laboratory results look like? Is there evidence there that our immune system is not working properly? And what we see for APDS, the IgG levels can be low, but often they're actually normal. And it's the idea that you have antibodies, they're just not very useful. And I will say that our clinical tests can only measure quantity, but they do not measure quality. So they don't really measure how good they are at binding the bacteria. They just show us they're there in normal levels or not. And then one way that we assess function is, do you have antibody response? But again, this is also just quantity, how much IgG against tetanus you have. It doesn't tell you, do you bind that bacteria well? So what's sort of the typical picture? And, unfortunately, I think well known to this crowd for immune deficiency, sometimes there's a long lack of diagnosis, and that's lack of immunologists across the country and sort of, referrals. And this is why education is so important. We try to educate our patients and educate other providers that we really need to pay attention to the history, how things evolve. This is an example that is more or less classical for APDS to how things evolve. Infections is the first thing we see, and in fact, the most common thing, cytopulmonary infections. Then we can see sometimes the gut disease, like in our patient. Other autoimmunity, so this is where, the other things come in, like the lung, for example, lymph nodes in there, having lung disease, having liver disease, having autoimmune cytopenias. Then, if we've had recurrent cytopulmonary infections long enough and it hasn't been properly treated, we start having some bronchiectasis and lung damage. And really the biggest thing we worry about is that by the time that these kids become adults, then there's a high risk of malignancy, and I'll explain why. Now, so in the context of the varied presentation, by and large, what is the thing that we most see? Respiratory infections. We can see a big spleen that's also pretty frequent, and then all the other things that you see here, right? But the pale in comparison with really how common recurrent cytopulmonary infections are. When you look at the pictures that at the end of the day got diagnosed with APDS based on the genetics, what were they labeled with before? They were labeled with these diagnoses. CVID, hyper IgM, lymphoma, right? Like I said, if we let things go long enough, and again, this is a disorder that hasn't been described in 2014. And you must recall we're only in 2023, which seems like, oh my God, that's like, 9 years away. But there are people who are now adults, right? Who really lived through the whole life with this disease not even being described. So maybe they, at this point they have lymphoma, and the oncologists, the adult oncologists, don't even know about what APDS means and really how do you diagnose this. This is why in the context of lymphoma, we have patients that are labeled with lymphoma, but really they have APDS. So the hallmarks, like I mentioned, recurrent cytopulmonary infections is really very prevalent. If this goes long enough, untreated and not treated well, you can get bronchiectasis, lung damage. More severe, you have to have resection because the tissue is just so damaged. And then if you have enough recurrent ear infections, you can eventually end up with hearing loss. And in the context of infection susceptibility to the family called the herpes viruses, where CMV and EBV are the most prominent there, is really very highly prevalent. And I will explain in a minute once I show you the immunological pathway why that is. Now, I talked about autoimmunity and autoinflammation. We talked about the gut, right? Having these lymph nodes-like structures in the gut, not normal. Having a big spleen. This is a picture of another patient, not mine, but really she looked like this, but in the size of a 5-year-old. And then also a big liver that can happen. This is because you have lots of lymphocytes, so immune cells in the tissues, places where they shouldn't be. And this is a picture again of the GI. This is also fairly common. And if you have a lot of inflammation in the gut, then you have diarrhea, bloody stool. If the inflammation goes on long enough, the tissue gets damaged, you can't absorb nutrition properly, and then there's poor growth. APDS, you have the immune deficiency. We talked about those, the cytopulmonary infections, plus the herpes virus susceptibility. And then the sort of, we call it immune dysfunction, meaning it's kind of, you have a little bit the worst of both worlds. Your immune system doesn't work well enough to fight infection, but yet it works too well and it fights against self, and it gives you autoimmunity and autoinflammation. And these are all the different organs that can be involved, and really across the board, there have been patients that have shown any one of these or a combination of these at presentation. And as I mentioned, right, like patients can have difficulty growing. If you have gut disease and you can't absorb nutrition, it makes it very hard to grow. And this is partially due to the enteropathy, but also in many inborn errors of immunity, we see problems with growth, even if the gut is fine. And it's the idea that you're having lots of uses of just body metabolism, energy, fight infection, kind of deal with everything else, and not enough sort of ability to grow. Oh, and then I spoke a lot already about the different pulmonary presentations and sort of the context of infection. But this kind of shows a little bit of kind of how this vicious cycle of the infection and then having lymphocytes in tissues where they shouldn't be occurs. And is the idea that your immune system doesn't work well enough, so you get infections that you can't clear. So then you get an infection. The immune system, I like to think about it, it's an army that never retrieves. So you have an infection, you can't fight it effectively because your immune system doesn't work well enough, but your army never stops. So you just keep recruiting more and more soldiers that can effectively fight, but they don't stop coming because they say, I gotta go on attack. And that's how you end up with a lymphadenopathy, right? Immune cells in tissues where the tissues are infected and you're just trying your hardest to eradicate the infection, but you can't. So then you have an accumulation of immune cells there, lymphadenopathy, and eventually leading to the hyperplasia. You do that long enough, damage the tissue, have bronchiectasis. If you have lots of immune cells that constantly are proliferating, making copies of themselves, the biggest concern here is you end up with malignancy, and lymphomas are the most common, and they tend to happen in the adult age. And really, while the mortality can be due to any of these complications, and lymphoma is the cause of mortality in 62% of APDS patients. So really, that is the biggest thing we try to prevent. Obviously, we want to take care of everything else, but this is really the risk that we're trying to prevent. So it's a very diverse picture, but I'm now hopefully going to explain to you why is it that APDS looks like this, and it's because of the intrinsic defect in the immune system. So I'm going to take you through that now. And then I will end with then once you identify which part of your immune system is not working well, then you can understand why the clinical picture looks like that. And then you have a target to go after for treatment. Okay, so this famous word, right? PI3 kinase. I'm not going to repeat to you this very long word, but there it is, what the acronym stands for. What's the job of PI3 kinase on a cell? And it has a specific job in T cells and B cells and NK cells, so your lymphocytes. But it also has jobs in other cells outside of your immune system. So just think that PI3 kinase is something that exists in most cells in your body, and they have very central jobs. They make cells grow. They have jobs in the cell metabolism, differentiation, meaning how you become from one type of cell to the other type of cell, proliferation. This is key, okay? Making copies of yourself, right? What is malignancy? What is cancer? Many copies of one type of cell. That's bad. And then survival of these cells. Also, if these cells make copies of themselves and they survive for a really long time, eventually cancer. Okay, and how does this work? All right, so PI3 kinase, there's different subunits. Again, these long names, disregard. But just think that PI3 kinase has a subunit called catalytic. That just means that's your job, right? So your job is to convert PIP2 to PIP3. So just think PI3 kinase has a job. But that job, like anything in the immune system, needs to be regulated. So you have and then to be able to achieve this job, you have different subunits. And these are the different flavors. Now, to regulate this function, right? Because you can't have this function on or off all the time. If it's on all the time, you get too much of these things happening. Your cells just keep multiplying for no good reason. Your cells need to be regulated. You proliferate when you need them. They should be quiescent when you don't. That's where the regulatory subunit comes into play. And these are all the different flavors. So they basically say, okay, now go do your job, or no, now don't do your job. How that looks inside a cell is a little bit like this. If the P110 delta turns on, all these things happen. And then you say, go and do your job, which is this goes to this, and eventually to here. Voila, you have survival proliferation. This guy regulates this guy. So think about the immune system. It needs to be very, very well regulated. So this survival, proliferation, differentiation, all these functions of the cell need to be regulated. So this does the job, and this tells the P110 when to do the job. If you have, right, and P85 here, ubiquitous expression means that it's expressed in lymphocytes, T cells, B cells, but many other cells of your body. P110, it's only in your immune system, primarily T and B, right? So there's a difference there already. And you have to regulate this function very, very well. And this is kind of what leads to all, right? This leads to a healthy immune system, that leads to a healthy cell elsewhere, outside of your immune system as well. If you have this working too much, then this is on all the time. So you have T and B cells that are proliferating, growing, activating all the time. That's like basically if you're driving a car and your gas is on all the time. Bad idea. That's APDS1. The regulatory subunit is the one that tells the 110, okay, now you go, now you don't go. If you lose the ability to regulate, then this is on all the time again. So here you are losing the brakes, right? This is the gas, this is the brake. If your gas is on all the time, bad idea. If your brakes are gone, bad idea also to be on the road. And this is APDS2 and this is APDS1. Recall I said that P110 is on the immune system only. So APDS1 is restricted to problems of the immune system only, with all the manifestations that I just described, due to infection and due to lymphocytes being places that they shouldn't be. APDS2, where there's problems with P85, you do have problems in other cells that are not in the immune system, including the neurological system. So this is kind of more broad than APDS1, but the immune system problem is the same in both. Now, if you have T cells and B cells, so what is the end product? If your gas pedal is on all the time, and this process is happening all the time, imagine that since you're a fetus, your T cells and B cells are just going, are just proliferating and basically functioning at maximal speed the whole time. Eventually, they will get tired. And that in the immune system is called exhausted. So if your T cells and B cells are always pushed towards proliferating and towards working very hard, they're pushed towards memory, and eventually they get really exhausted or senescent. So words to say that your immune system is just pooped out and tired, that's exhausted. It could also senescent means old. And you would imagine, why does a 5-year-old have an old immune system? Well, because their immune system has been working in overdrive since they were a fetus because of this genetic defect. So because you have T cells and B cells that are proliferating all the time, that's why you have big lymph nodes. And that's why you have all this excess of lymphocytes. They gotta go somewhere. They go into the tissue and they cause problems in the tissue. Eventually, you let them go long enough, you have one type of cell called a clone that is then going to become malignant and it's just going to go in overdrive. If you have T cells and B cells that are exhausted, they're actually non-functional anymore. So they're out there causing problems because they're all activated, but they're being activated for so long that now they can't even work well to fight infection. All they can do is go invade tissues, but they're not effective at fighting tissue because they're senescent, they're old and exhausted. And then this is why you get pulmonary infections, and your T cells are very important for the herpes viruses, which is also why you get problems with EBV and CMV. There's nothing here about the NK cells, but the NK cells are affected also, and those are very important for EBV and CMV, which is why you get lots of problems with that. So, so coming back to that, if you have the hyperactive PI3 kinase, the P110 delta, that subunit, you have senescent or old T cells. And this is also why APDS used to be called PASLI. I don't think we use that terminology anymore, which is to describe P110 delta activation with senescent lymphadenopathy immune deficiency. Again, as I mentioned before, you got all these lymphocytes running rampant all over the place. You have big lymph nodes, and then you can have the T cell findings that I described, and then lots of B cells that are exhausted. They're moving towards memory. They can't anymore because they're exhausted and they're stuck there in the transitional stage. And that's also why sometimes you do see low IgG. However, if you don't see low IgG, that's because, again, they have been proliferating for a long time. They have pushed the B cells to make IgG, but they become ineffective. The IgG you have is not effective. It's abundant, but it's not effective. So when you have this type of picture, lots of senescent cells, lots of immature cells, then you kind of tip the scale towards, instead of normal, healthy, functional cells, they are deficient in functionality, excess in senescence, and then you end up with all the complications that I talked about. We talked a lot about genetic testing, and this is why we advocate for genetics, because while I can do the clinical labs that I discussed with you to kind of guide me towards saying, I think you might have APDS, really the proof is in the pudding, and that's identifying the genetic mutation. These are a collection of the mutations that have been described today, but every year we'll learn more. This is the APDS1, so PI3 kinase P110 delta, and this is P85. This is kind of what has been described. So everything in the context of genetics, right? You have 2 copies for every gene, one from mom, one from dad. In this case, for the APDS, you need 1 bad copy. And that could come from either mom or dad. So that's called autosomal dominant. You only need 1 bad copy. So if you have an autosomal dominant scenario, 50% chance that the children will have it as well. However, we see de novo mutations very frequently. That means that there's a healthy history. Nobody in the family had it until the child that we see in our office. And that's actually also pretty common. The question will become about genetic counseling for that child when they grow up and then they go on to have children. Their children will have a 50% chance. Here says nearly 40% had a family history. But that means that 60%, still the majority do not. So don't be dissuaded to not think about it if there's no family history. Okay, so back to our patient, what do we know? I was very happy we got to a specific diagnosis for her. And in the pathway that I just showed you, so let me come back here again. You see that, this pathway, this gets turned on, all these things happen, you eventually end up turning on mTOR, and that leads to the functions of the cells that I described. So the ideal scenario, right, would be to block this. But back in 2015, I didn't have a way to block this. What I did have is a way to block this. And that's not as great, but the end product is that you end up activating this. So then I said, well, we can at least treat this, right? We can target this. And there is already in place an mTOR inhibitor. That medication is called rapamune or rapamycin. So I did start the patient on rapamycin, and then there was actually improvement of the symptoms. However, at the time that I started the patient on, there were already some trials on PI3 kinase inhibitors. So idelalisib was already FDA approved in 2014 for malignancy, but this is not exactly a selective inhibitor. Leniolisib, which then there were studies already when I started my patient, I was aware that there were studies undergoing this is a P110 delta inhibitor, right? So that's the very specific target that I want to go after. The studies were starting, and this was published in 2017, where they showed that you can target P110 delta with leniolisib. And this is the data from that paper. So recall that I said, if you have the pedal gas on always, the proliferation, all that pathway in the cell is happening all the time, it's on. Phospho AKT is a way to show that that pathway is on, so it's on all the time. And then anti-CD3 is basically a way where you have to engage the cell to turn on that pathway to do those things. And what you see here is that you give different concentration of drug, and the more drug you give, with the blue line being the highest concentration, the more you can shift the induction of this to the left. That means you can decrease it. That means you can decrease the proliferation. And that's also shown here in the bar graph. At the highest drug, right, when you have no drug at all, there's this much engagement of that pathway. As you start giving drug and you start getting into higher and higher concentrations, you're able to actually push that down. So there's already in 2017, this is what was published. And what you show is that as you increase the dose of the medication, you start driving down the number of transitional B cells. Those are the ones that are stuck in the immature stage, and you start pushing up the number of B cells that are naive. So you start, actually recall that I said the immune system is pretty tired and old, senescent and exhausted. So you actually start pushing new baby B cells out. These are the naive B cells. The T cells are senescent, so old, CD57 is a marker of that, and you can see that those numbers go down. So your old T cells go down. PD-1, it's a marker of exhaustion. Your exhausted T cells go down. And this is a picture of that. This is where your naive, fresh baby cells will be. This is a patient untreated, then they get treatment after 84 days, and you get more of these cells. This is a patient where these are the exhausted or activated T cells. These are senescent 57. These are activated. And then after 85 days, look kind of the decrease that you see there. So this was very exciting, published in 2017, where it's a little bit of proof of principle. Then fast forward 2023 this year, and actually now we have the drug that has been FDA approved, and it's called leniolisib for the generic name, Joenja for the trade name, and that's made by Pharming. And this is how the trial was conducted, with the screen 32 patients. Patients were randomized to either placebo or treatment. On a 2-to-1, say 21 patients got the drug, 10 patients got placebo, and then everybody that went into the trial completed the trial. The treatment lasted for 12 weeks or 3 months, and this is at the 70 milligram twice a day dose. So you can see here what was their outcome of the trial, the endpoints. Recall, we said they're big lymph nodes. So the lymph nodes were measured, and you can see that on drug, the patients on drug had decreased of the size of the lymph nodes. The patients on placebo did not. And then the spleen also decreased in size. And this is a picture, right? This is the spleen that you can see in the before and after. Really, I think the most remarkable decrease is the lymph node size. So this is before and after, and then this is before and after. Quite remarkable. Then going back to the laboratory data, those baby B cells, the naive B cells, you can see placebo group, treatment group, you start popping out some of the new naive fresh B cells. Those transitional tired B cells, you see them going down. And then the plasma blasts, I think this is a little, I think that the effect we get here is more moderate, but really I think this is the important piece. Plasma blasts are your cells that make antibodies, and that kind of, you do see a decrease in them. So the proliferation, the multiplication of them gets lower, but this is, I think, more impressive. And
Dr. Hseih, I'm so sorry to interrupt you, but I just want to make sure we are able to get to the couple of questions that we have.
Yes.
So if we can wrap this part up in just a couple of minutes, then we can get into the Q&A.
Perfect.
Sorry. Thank you.
I'm pretty close. So here are the senescent or the old T cells. Now you can see that in the in the treatment group, they go down. And then you start having more naive T cells, so some of the fresh new baby T cells. So this is all the data that was published in 2027. So in conclusion, we've learned a lot about inborn errors of immunity, but so much more to understand. What we learn about inborn errors of immunity, we can apply to a healthy immune system. And precision medicine, the idea that you can target a specific pathway, getting the drug that is specifically for the disorder you have, is becoming a reality. So thank you very much. This is my research lab. We work on inborn errors of immunity, and we climb mountains. And I like to say we work hard and we play hard. And I will take questions now. Okay.
Wonderful. Thank you so much, Dr. Hseih. So how this is going to work, I'll just read the questions from the Q&A out loud so everyone can hear them and see them, and then we'll have you go ahead and answer. So just give me one moment.
So I have it open here. I can read and answer. How's that?
Sure.
So
go ahead.
Here is, does APDS present with any prenatal or neonatal symptoms, such as higher birth weight, excessive amniotic fluid, or newborn jaundice? Not that I know of. So the answer to that is no. So no prenatal. And then neonatal, since infancy, I think failure to grow is probably the thing that we see closest in youngest age in infancy. Does leniolisib increase the risk of lymphoma? It does not. What it does is decreases the risk of lymphoma, right? So the goal here is, as you saw in the data, if you decrease the lymph node size, if you decrease the amount of exhausted, tired, activated T cells, you decrease the risk of lymphoma. If a patient is diagnosed with CVID, low IgG, elevated IgM, looks like APDS, and had genetic testing for primary immunodeficiency in 2018, which includes PI3 kinase genes that came back without any variations, does it make sense to retest? So the answer is yes, you can retest. So I should say how the variants are outputted is based on the data available in the literature. So therefore, if the testing was analyzed a while back, then, it's possible that there's new data now. However, really the problem here is analysis, right? So do you need to draw blood and do the sequencing again? No, the sequencing is done and the data, your code is your code. What really could be done again is comb that code and say, now we know more different genetic variants. Because the thing about it is you only find what you're looking for. So if you only know of 20 mutations, you're going to look for those 20, right, in the genes. And if you're not any of those 20, then they're going to say it's not that. So if now we know 30 instead of 20 compared to 2018, well, then if we reanalyze the data, we might be able to pick up some new ones because there's new ones published. However, there's also new ones that are never published and are called variants of unknown significance, meaning is a change in the genetic code in that gene, but hasn't been published to say is pathogenic. That's very common. And really the next thing that should be done if that appears is to really do the functional assay and assess if that catalytic enzyme, if that function is increased. That can be done on the research side. And it's not a clinical assay. So some companies will actually go back and recomb the data later. And this is something you can discuss with your provider to reach back to the company and ask, can you recomb the data? However, if the same analytical pathway is applied without incorporating the new ones, you might end up with the same result. So it's really about the analysis of the data, not so much about doing the assay again. In the PI3 kinase hyperactivity slide, what does the inverted CD4-CD8 ratio look like? Why is this important? So T cells are divided in CD4 T cells and CD8 T cells. Normally, the normal ratio is 2:1. So we have double the amount of CD4s than CD8s. Why is that? CD4s tend to have many jobs. CD8s are important too, but the CD4s are the ones that help the B cells. So in addition to their own T cell job, they also have to help the T cells. Now, in PI3 kinase, you actually have more CD8s than CD4s, and that has to do with how important that P110 delta function is so much more for CD8s than it is for CD4s. So if it's on all the time, it's going to push the CD8s more than the CD4s. And that just gives us the clue of this hyperactivity. And that really is the level of importance. We tend to also think that that kind of indicates that you're having your T cells fight a viral infection that you can't fight and you keep trying. So that's the other clue that we get. Where does genetic testing fit into your CVID diagnosis? I think if you ask many of us now, we would say that really everybody that meets CVID diagnosis should get genetic testing. Whether that's approved by insurance all the time, I think is the question. But many of us that work at academic institutions, if your insurance doesn't approve, we have ways in which we can support that. How quick do you genetic test your patients? I have a pretty low threshold to do that, but that also is because I think it's useful to genetic test if you know what to do with the data. I think many specialists outside of immunology will do genetic testing, but then you only have a useful test if you know how to use the test, right? It's like a computer is only powerful if you know how to use the computer. So if I think someone should move into genetic testing quickly if they know how to analyze the data. And then you know what variant of unknown significance means, you can understand how to test that, and you can sort of see whether it means anything or not, as opposed to, I don't know what to do with the results and what they mean. So I would say if you're at a place and you're seen by someone who is very well versed in genetics, and they say, after they see you, I have a strong suspicion that there's a genetic etiology here, then it should be done, and really in the first visit. If someone is diagnosed as CVID and they have a pathogenic PI3 kinase PI3 variant, should the diagnosis be changed to APDS? Yes, it should, because that actually is a separate ICD-10 code. So for the purpose of billing, insurance approval of things, the ICD-10 code is different, which means that you will get different things being approved. For example, you might get Joenja or leniolisib approved with APDS ICD-10 code, but you might not with CVID ICD-10 code. But IVIG, you can get approved with either because it's indicated for either. Make sense?
All right, wonderful. Well, I think I know we're running a little over on time, so thank you so much, Dr. Hseih, for bearing with us a little bit past our endpoint, and thank you to our audience. We appreciate you sticking around. Just a couple more slides before we wrap up, but we want to thank you so much, Dr. Hseih, for this wonderful and informative presentation. I think this will be super helpful for our APDS community, which we know is growing now that it has its own code. We're very, very excited about the treatment as well. So thank you so much for sharing all this great information. To our audience, we hope that you'll remember to take advantage of all the resources that we have to offer here at IDF. If your question was not addressed during the program, or if you didn't want to ask it in this public setting, you can go online and submit your question to Ask IDF. Visit www.primaryimmune.org/ask-IDF, or you can give us a call at the 800 number on your screen. To find our materials on APDS, you can just go to primaryimmune.org and search APDS in the toolbar. And you can also visit the IDF Resource Center, where you'll find videos, resources, podcasts, and more. And I did want to add that this presentation will be uploaded to the IDF YouTube channel and website, so you'll be able to find it and refer back to it later. All right, it's a busy spring here at IDF with lots of great upcoming programs. We have our next in-person education day in Weehawken, New Jersey on Saturday, May 6th, followed by 2 lunch and learns on May 10th and May 31st. Be sure to follow us on social for the latest news and updates. And lastly, we are so excited to share that registration is now open for the 2023 PI conference. Visit primaryimmune.org/conference to register and learn more. And before we go, we want to again thank our core services partners for their generous support of today's program and many other initiatives here at IDF. Thank you so much again, Dr. Hseih, for leading today's program and for sharing your time and expertise with our PI community. We so appreciate you. And thank you everyone for joining us this afternoon. Have a wonderful rest of your day.
Thank you so much for having me. Bye.
Thank you. Bye-bye.